Good morning, Chicago. Today is January 17, 2023. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health, and as always, we are here to take your questions live. Questions about COVID, questions about other things related to public health. You'll be able to put your questions directly into the box below or use the hashtag AskDrArwady on either Facebook or Twitter. So as always, let's go ahead and start with some of our local data. If you go to chi.gov/COVID-, that will bring up our dashboard. We are still updating this at this point every weekday. There's a good chance that after we get through sort of this post-holiday time, if things continue to look okay, we may be changing to a weekly update on this. Not a decision made just yet, but at the moment we are still updating daily, and you will see as we pull this up here, everything is green, and that makes me very happy. We're averaging just under 400 laboratory confirmed cases a day. Not nothing, especially when you know that there are many, many, many more self-confirmed with home test cases than there are laboratory confirmed cases. But nonetheless, looking good, certainly nothing like we were seeing during major surges both of our last winters. And we know that whenever people are coming into healthcare settings, they're going to urgent care, they're going to their doctor's office, they're going to the emergency department, or any of the outpatient lab COVID testing. That's what shows up here. So it's also a little bit of a proxy for people seeking healthcare. You can see we're averaging about 20 Chicagoans every day being newly hospitalized with COVID, getting close to 50,000 cumulative hospitalizations. Probably get there in the next few months. We are averaging just under 1 death per day, still doing about 2,000 vaccinations every day, so that's good news. And just about less than 2.5% of our emergency room visits right now are due to COVID illness, and just under 5%, 1 in 20 of our hospital beds is taken up with somebody with an active COVID infection. So all is looking pretty good. I'm going to go ahead and turn to some slides here, and we are going to have a focus on vaccine safety based on some questions that were coming in. Sorry, just switching this up here. There we go. Okay, so first of all, those of you who were with us last week, we had two guests, Dr. Stephanie Black, Mr. Christopher Shields, who lead a lot of our work in communicable disease as well as in emergency preparedness. And they talked in great detail about the Uganda-Sudan virus outbreak. And as expected, it was formally declared over as of January 11th. That means that we have been able to stop doing entry screening at O'Hare for any travelers from Uganda. We've also been able to end public health monitoring. We've been following anyone who is in Uganda for 21 days. And just want to say thanks again and congrats to the team. Based on COVID, we do remain at a medium COVID level. You can see in terms of cases, we're at well under 200 cases per 100,000 population. The Cook County data comes from the CDC. It is still pending, but we'll update it when it's available on the website. And admissions per 100,000 population are still over that goal. So still a good number of people, especially in the larger Cook County catchment area, being admitted to the hospital with COVID. But our percent of inpatient beds is well under 10%. So they are still at a medium level. And last week, 14% of U.S. counties in orange were at a high COVID level, and 38% were at a medium level. We continue to get a lot of questions and interest in XBB.1.5. That is, yes, the subvariant of Omicron that is also, some people are starting to call it the Kraken, K-R-A-K-E-N subvariant. I want to be really clear that Kraken is actually not a scientifically named term. It is not a letter of the Greek alphabet. It is the name of the Seattle hockey team, apparently. But regardless, this XBB.1.5, it's a recombinant or a fusion of two different BA2 variants. It is all still Omicron. That is the most important thing, meaning that the updated vaccine to help better protect against Omicron looks like it works okay there. The treatments that we have, it works okay there. No major shift, but it is the most contagious subvariant of any kind that we have seen yet. So here in the Midwest, also reflecting what we see in Chicago, in dark purple here, you can see up at the top in the most recent week, this XBB.1.5 was about 14%. That's up from about 7 to 8% a week ago. So continuing to increase as we would expect, but still relatively smaller number compared to the rest of the country. If we look across the US, again, that dark purple is the XBB.1.5. You can see in Region 5, sitting over Illinois and Chicago, that's that 14% that's purple, whereas out on the East Coast, nearly everything they're seeing is that XBB.1.5, probably part of what's driven that relative surge on the East Coast. And if we only show the dark purple, the XBB.1.5, you really get a sense of that. More than 80% out on the East there compared to 14%. So I do expect that will continue to increase here, but get up to date with your vaccine. And other than that, know that it's more contagious, but there's nothing else that you need to do right now. And we are mainly concerned if we were to see a new variant emerge that was not Omicron. We have not seen that in a year. So a new variant of concern, not on the horizon at this point, though XBB.1.5 certainly demands some watching. Just want to remind you that since the Omicron variant became dominant in Chicago, unvaccinated Chicagoans in red have been almost 3 times as likely to be hospitalized with COVID than up-to-date Chicagoans, those who are vaccinated or boosted. And we do continue to see this be really, besides age, the top factor for being hospitalized with COVID. So please make sure that you are up to date with your vaccines. If you know anybody over 50 and especially over 65, it's really critical that they've had a vaccine this fall and winter against COVID. So here's where we're doing as far as that updated booster coverage. We are beating the US, but it is nothing to brag about because uptake really has been fairly anemic. We passed the 500,000 mark right around New Year's, and we're now at 529,000 doses of that bivalent booster have been administered to Chicagoans since authorization. You can see that's about 20% of the population, depending how you break it down. About 21% of those over 18, 20% of those over 12, 19.6 of those over 5. And yes, those are higher than the national averages at 18, 17, and 5, but still concerning. The thing I'm the most worried about here in Chicago and across the U.S. is that population over 65. We are right on track. The U.S., 39% of people over 65 have had that fall 2022 booster. And here in Chicago, 38.9%. We're right on track there. And that is the group I worry about the most. That is the group we're seeing hospitalized most often. That is the group we're seeing die most often. So please ensure those who are older, just double check with them. Make sure they've had a vaccine, a COVID vaccine, since Labor Day. If not, they're not up to date. So overall, 28% of eligible Chicagoans, up 1% from a week ago, have gotten that updated booster. This is if we look at those who are eligible, meaning not all Chicagoans, but those who had their original vaccines. So not people who have said, I'm never going to get a COVID vaccine, but people who got their first vaccines. And there too, you can see this really differs by race ethnicity. More than 40% of white non-Latinx Chicagoans and more than 30% of Asian non-Latinx Chicagoans have had that updated booster, but only 24% of Black non-Latinx and 19% of Latinx Chicagoans have had that updated booster. So we continue to put extra resources and outreach, especially in communities with a lot of Black and Latinx Chicagoans. You can see, though, we have made some nice improvements in terms of the increases, up 3 to 4% compared to a month ago, and across all groups. So that's been good to see. And on the bottom there shows you by age group, again, among eligible Chicagoans. Those in their 70s are the only group that are more likely than not to have had that vaccine. And you can see even among those over 80, that's our highest risk group. People are less likely to have had it than not to have had it. And that's the group that we worry about the most. So last week on Facebook, I got a good question from Christy M. Van Ryn. She said, Dr. Arwady, please discuss the CDC's VAERS data. It shows there's 1 million COVID-19 vaccine adverse events. There's 30,000 deaths. Please discuss the risk of myocarditis, blood clots, cardiac arrest, heart attack from mRNA vaccines. You push these shots, say they're safe and effective. The fact is that they are not. So, Christy, thank you for the question. I promised that we would talk in some more detail about VAERS, as well as about vaccine safety, because I really want to make sure not just you, but anybody who's watching who has questions or concerns about vaccine safety or efficacy, I want you to see some of the data that we use for how we monitor that, but also how I can feel very confident in saying that the vaccines are safe and effective. So let's start with your question about VAERS. VAERS is the Vaccine Adverse Event Reporting System. You can go to vaers.hhs.gov if you want to read about it, if you want to submit an adverse event. It is one of many safety monitoring systems that help us detect any possible safety signals, they're called, for vaccines as early as possible. And then if any signal is detected in this reporting system, but also in any of the other vaccine reporting systems, you look across systems to see if you're seeing an issue. We're going to talk a little bit about this. So it's co-managed by the CDC and the FDA, the Food and Drug Administration. And first, I just want to make sure you understand that for any reported event, there is no cause and effect relationship established. Because you see an adverse event in VAERS, that is not documentation that a vaccine has caused the event, because this system is not designed to determine if a vaccine caused a health problem, but it's especially useful to see if there's an unusual or an unexpected pattern of adverse events that could indicate any kind of safety problems. So that way the VAERS can provide the CDC and FDA with valuable information that additional work and evaluation might be necessary to see if there's a safety concern. So here's the top sort of 6 things to know. Number 1, it's a national vaccine safety surveillance program like I just noted. It's meant to detect unusual or unexpected events after a vaccine is being used in the general public. And number 2, it's passive, and that means it relies just on people who send in reports of experiences after vaccination. We also have active surveillance systems where you're monitoring a subsection of people who have received vaccine, or you have ways of following large groups of individuals seen in certain health systems where you're not dependent on people having to report, but you're actually looking at the whole population. So number 3, and this is the most important one I want you to understand, that VAERS accepts reports from anyone, including patients, family members, healthcare providers, and vaccine manufacturers. And along with that, number 4, healthcare providers and vaccine manufacturers are required by law to report certain events after vaccination. So if, for example, somebody has an anaphylactic reaction, a very bad allergic reaction to any vaccine, this isn't just for COVID, it's for any vaccine, the provider by law must report it. If the people who manufacture vaccines become aware, you have to report it. But back on number 3 there, it can accept reports from anyone. And I will tell you that there has been a big increase in reports that may not all be based in fact. So there's been an increase in reports, for example, of people putting in a report around events that frankly have not happened. People have submitted reports into VAERS saying the vaccine, made me see aliens. The vaccine made me, start dancing a jig, whatever it is. There have been reports in saying that Daffy Duck's voice, right, is caused by the vaccine, or reports on celebrities saying that, this celebrity had this event, I want to report it into VAERS. So there is some work to try to monitor for reports that may not have a basis in fact. You have to give contact information when you report into VAERS, because the idea is that if you have had an adverse event It's really critical that if this is part of a pattern, that they can follow up, to get your medical records, to follow up with how you're doing. And so generally, if there are sort of obvious examples of people reporting into VAERS, probably not a true event, especially if they don't give contact information, those can be excluded. That is not the great majority, to be really clear. Most adverse events reported into VAERS are things like fever or sore arm, et cetera. But if there is not contact information, and especially if it seems like it is not a true report, they will sometimes exclude those. It actually is illegal to make a false report into VAERS, but in truth, people are not usually prosecuted. But healthcare providers must report into VAERS. So number 5, VAERS is not designed to determine if a vaccine caused or contributed to an adverse event. A report to VAERS does not mean that the vaccine caused an event. Healthcare providers, for example, if somebody dies within 2 weeks after getting any vaccine, you are required to report that death. Even if that person died from, something that you don't think that it's related to the vaccine, you are still required to report it because they want to be able to keep track of that. But it doesn't say that the report has contributed to the event. It's sort of a little bit of a messy signal that makes sure if we see something, you can investigate it further. And so as number 6 says, if VAERS detects a pattern of adverse events following vaccination, other vaccine safety monitoring systems conduct follow-up studies. So it's really critical. I encourage you to go look at VAERS and explore it. I think it's a really interesting set of data, but you need to understand its limitations and know that it is one system that gives signals that you then look at in other studies and other systems. So the strengths, I would say, are that it accepts reports from anyone. That's a strength because perhaps that way you're not limiting yourself in terms of people who may have concerns about their vaccine or have had an adverse event that they're concerned could be related. So that really lets it act as an early warning system to potentially detect very rare adverse events. But more than a quarter of the VAERS reports that come in don't even come from people in the United States, for example. Like literally anybody can report into this system. So another strength is that it collects information about the vaccine, the person vaccinated, and the adverse event. And then the scientists will get follow-up information on serious reports. If there's a report that comes in that someone has had myocarditis or someone has had a heart attack or someone has had some serious event, absolutely, that's the setting in which there is further investigation. And patients, doctors, you get sort of follow-up data requests, and you're required to sort of submit them to be able to investigate further. And all data, I think a strength, without identifying patient information are publicly available. But it's important when you're looking at it that you do understand that that's a combination of reports coming in through medical sources and through just anybody. So the limitations, I think, as a passive reporting system, it means that there's not automatic collection about adverse events. Someone who has had or isn't aware of an adverse event following vaccination has to file a report. They're submitted by anyone, so sometimes they lack details or contain errors, and sometimes, we have seen perhaps anti-vaccine advocates want to submit some of that false information. Again, it's not the majority of it, but that can be a limitation. So VAERS data alone cannot determine if the vaccine caused the reported adverse event. So Christy, to your question, you're saying, there have been more than 1 million adverse events. Like, no, not 1 million adverse events that are caused by the COVID vaccine, 1 million events that are in this system, which then get further investigation. Is there a relation? Is there a pattern? Is there any difference in these in people who have had the vaccine versus not? Because we know people have heart attacks all the time. Are they more likely to have a heart attack after getting the COVID vaccine? That's the question, and that's the study that you do. Again, more than 12 billion vaccines given around the world. So it really is this limitation that's caused some confusion about the publicly available data, and especially the number of deaths. In the past, there have been some instances where people misinterpreted reports of death in VAERS as death caused by the vaccine. Just because a death follows vaccination does not mean death is caused by vaccination. Even if somebody dies in a car crash, technically it gets reported as a death following following vaccination, even though we have no reason to think that that is related. So they accept all reports of adverse events without judging whether the vaccine caused the adverse health event. Some might represent true vaccine reactions, some might be coincidental and not related to vaccination. And so you cannot establish a causal event from VAERS reports alone. We know that the number of reports submitted to VAERS goes up when there's more media attention and increased public awareness. There's a video circulating right now about sudden death that uses a lot of images and a lot of examples of people who actually who had sudden death even before the vaccine was available, but they pulled it together trying to make a link between sudden death and the vaccine. And I just want to be very clear that when there's increased attention, we also tend to get more reports. It's not possible to use VAERS data to calculate how often an adverse event occurs in a population. Okay, so to get into the details here, VAERS creates what's called a signal. Not just VAERS, but any vaccine safety monitoring system can create a signal. Some of you probably did the VSafe, which was after you got a vaccine, you had the opportunity to follow up and submit to CDC. Did you have any side effects? Did you have any adverse reactions? That's a completely different system than VAERS. So again, if we see a pattern of adverse events or an unusually high number of adverse events, that's called a signal. If a signal is identified through VAERS, there's then further studies to see, does that signal represent an actual risk? So they'll look at other safety systems. There's something called the CDC's Vaccine Safety Data Link that looks at large data sets from healthcare systems across the country. There's the Clinical Immunization Safety Assessment Project that looks at individual events that occur after vaccination. Is this likely to be related? It involves medical examiners, experts, research scientists, et cetera. And so just to kind of take a step back on vaccine safety, there's a blogger that I like. Her name is Caitlin Jetelina, and she blogs at Your Local Epidemiologist at substack.com. So I would refer you to her if you want to see some more details of this. But let me explain to you sort of how I'm thinking about it. So, as she notes, and as I absolutely agree, we have more evidence than for any other vaccine or disease in the history of humanity that the benefits of COVID-19 vaccines greatly outweigh the risk. But there are people like Christy and others who write in who continue to worry that vaccines are seriously harmful or even killing people. I get emails from people who think that the goal of vaccination is to depopulate the planet. So let's play this out for a second. If this were true, if the COVID vaccine were killing people, we would expect those who are vaccinated for COVID to be more likely to die than those who are unvaccinated, right? But in fact, the opposite is true. So first, I regularly show you our Chicago data for COVID-19 deaths, hospitalizations, cases. This is on our website. And this is tracking COVID deaths specifically, people who die from COVID, where overall in Chicago, people who are unvaccinated in the red line there are 5 to 6 times more likely to die than those who are up to date with their vaccines. And we have very clearly seen that increased risk of COVID death in those who are unvaccinated. But if you take a step back and look at all deaths, we also see that COVID vaccines save lives, and not just in Chicago. So this is data out of England, a relatively recent study that looked at all-cause deaths by vaccination status. So this is anybody living in England who died of COVID or a car accident or a stroke or a drug overdose, anything they died from, didn't matter, age adjusted, and they compared simply, were you vaccinated against COVID or were you not? And so what you see is that the all-cause death risk in purple here, this is over 2021 and 2022, people much, much more likely to die if they are unvaccinated in purple here compared to if they're vaccinated. And again, the vaccinated here is any number of doses. And most of these deaths are, of course, from COVID. You see, as time goes on, the impact has changed. These lines start to come closer together because we have highly increased vaccination rates. We have survivor bias, meaning people who survive from COVID the first time, if they're getting it the second time, they're probably less likely to die. We have infection-induced immunity that's starting to play a role here. But even now, you are more likely to die in England of anything if you are unvaccinated compared to if you're vaccinated. So that's an example outside Chicago with real world data. Also focusing on younger people because I was hearing from folks after the cardiac arrest of that football player. I've heard, we hear from people, Lisa Marie Presley died of a cardiac event. There are a lot of people who will automatically say, in people, I think she was in her 50s, but especially when younger people die, there's a tendency, or we've seen people want to try to say that's related to COVID vaccination. So I want to really emphasize in that younger group and show you some data. So we've not seen excess deaths above the expected baseline, even in 18 to 49-year-olds as a result of the COVID vaccine. What we have seen in this group is excess deaths as a result of COVID infection. So if you look at this data over time, April 2020 is basically the beginning of COVID, and that in green here, just in 18 to 49-year-olds across the U.S., this is excess deaths from all cause. So a lot more people have died than died prior to COVID being here, right? COVID remains the number 3 cause of death in the U.S., and it's why life expectancy has fallen for everybody in the U.S. But if you look here, the purple are COVID-19 deaths, meaning 18 to 49-year-olds dying of COVID. And you can see it's been as high as 6 or 7 per 100,000 in 2021 during the Delta, and then again a spike during Omicron. But you see that the excess deaths in green track really tightly with the COVID deaths in purple, even for this age group. So it's not that we saw excess deaths kick up when the vaccine became available in 2021. We saw them actually kick up in 2020, and those patterns follow when we've seen surges in COVID infection. They've not followed when vaccines have been available or changed. So no excess deaths related as a result of the COVID vaccine, even in 18 to 49-year-olds. And if we look specifically at diseases of the circulatory system, which is where the most focus has been, I think for good reason. Heart attacks and blood clots, for example, specifically in 18 to 39-year-olds. So this is US data. And if you look, this is on the left here, this is showing you going back before COVID, we really were seeing a nice drop, really year over year at circulatory system diseases in 18 to 39-year-olds, and deaths specifically, I should have said. And so, that's a combination of more AED availability, better health, et cetera, better treatments. We were seeing a nice drop here. And then look what happens. Here comes the beginning of the pandemic, and you see a huge uptick in circulatory system deaths in 18 to 39-year-olds, which thankfully are rare at baseline. And the thing that makes that shoot up is related to COVID and COVID infection. So on the right here, again in red, you see circulatory system deaths over kind of the 12-month period. So you see that the black line here marks the beginning of vaccinations. And thankfully, we finally see these circulatory system deaths stop increasing post-vaccination like they had been. You see in the green line here, this shows the percent of young adults that are fully vaccinated. So finally, we were able to get young adults vaccinated against COVID, and we're able to stem this increase in circulatory system deaths. So again, increase in circulatory system deaths, yes. Related to vaccine, no. Related to COVID infection, unfortunately, likely yes. And there's been some really, where you go and do more studies looking at the risk of adverse events after vaccine and after SARS-CoV-2 infection. This is a New England Journal of Medicine study that came out last year. That's really the top medical journal. BARDA is the lead author if you want to look it up. This was really comparing, in orange is how many events per 100,000 people happened in people who were infected with the SARS-CoV-2 versus in blue, those who had recently received, in this case, the study was of the Pfizer vaccine. And so across the bottom here, you're basically seeing what is the risk of these different events as reported after different events. So if you look at acute kidney injury, you can see that in orange, 125 events per 100,000 persons in people who had COVID-19, the disease. That's a pretty high risk of getting acute kidney injury, whereas actually in those who had recently been vaccinated with a Pfizer vaccine, it's actually -5. It was a little bit protective. Probably the vaccine isn't necessarily protective. We don't pay too much attention when they're in these, sort of in the 0 to 20 kind of range. But the point is, 125 times basically or more likely to have acute kidney injury. And if you go across arrhythmia here, arrhythmia means a bad heart rhythm. It is the thing that can cause sudden death in especially younger people. You see that risk, 166 events per 100,000 persons in people who are infected, and then basically no increased risk. In fact, slightly negative risk or a protective risk for arrhythmia in those who had been vaccinated. So again, the infection causes arrhythmia, the vaccine doesn't. Deep vein thrombosis, that's the blood clots, especially in people's legs, etc. 43, times more likely in people who had the event. 43 events per 100,000 persons versus, none. Again, slightly protective in those who had the vaccine. Herpes zoster, it's in the close range, perhaps slightly more in those who had been vaccinated. Intracranial hemorrhage, that's a brain bleed. When they're in these sort of smaller, near zero, less likely to be statistically significant. But again, no increased risk with vaccine. Lymphadenopathy is the one that definitely was showing up more in those who are vaccinated. What is lymphadenopathy? Swollen lymph nodes. So when you get a vaccine and your immune system is learning the immune system lesson, your lymph nodes are where your immune system lives in your whole body, but you have a lot of cells in your lymph nodes. And so you can get some swelling of the lymph nodes. It's not dangerous, it goes away, but it's one of the reasons why, for example, if women get a mammogram, they will sometimes ask, did you have a vaccine recently? Because you can see some increased size in the lymph nodes in people who have recently had a vaccine. But it's so more lymphadenopathy, you can see 78 times in those who are vaccinated compared to those who are recently infected. But now over here on the right are the ones that have gotten the most attention. So myocardial infarction is fancy word for a heart attack. 25 events per 100,000 population in those who are infected with SARS-CoV-2, 1 per 100,000 in those who were recently vaccinated. 25 times, more likely to have a heart attack in those who are infected compared to vaccination. Myocarditis, that's inflammation of the heart muscle. That one has gotten a lot of attention, and there is a signal on that, which I'll talk about. 11 events per 100,000 population in those who have been infected compared to 3, not 0, you'll note, but 3 in those who have been vaccinated. Still, 3 to 4 times more likely to have the myocarditis, which again, most people do recover from. But nevertheless, you want to watch it. Pericarditis, that's inflammation around the heart. 11 times, 11 events per 100,000 in those who are vaccinated. Those who are infected versus 1 in those who are vaccinated. And then pulmonary embolism, that's when you have a clot in the lung. These can be fatal. And 62 events per 100,000 in those who are infected versus, again, sort of -1, no increase in those who are vaccinated. So I went over that in some detail just because this is where you really want to pool together safety data and look at studies like this if you're trying to understand, is there increased risk? So let's talk about legitimate safety signals, because there are some. There's no medical intervention where the risk of side effects is 0. But the risk of serious side effects with the COVID vaccine is extremely small, and the benefits of the vaccine far outweigh those risks. So first of all, just to sort of ground this a little bit, chance of getting hit by lightning, it's about 1 in a million. So where have we seen some legitimate safety signals? Whether they were detected in VAERS, whether they were detected in the vaccine data systems, there's all different systems that look at it. These are ones that we've had legitimate safety signals. So first of all, the risk of serious allergic reactions or anaphylaxis. It's about 5 in every 1 million vaccine doses. So that remains very, very low. Again, 1 in a million chance of getting hit by lightning. So 5 in a million, more likely to have a severe severe allergic reaction. It's still extremely rare, but it is a finding that has been associated. It's a legitimate safety signal that has been borne out. And so what do you do about it? You'll remember that especially when you were first getting your COVID vaccines, you had to sit for 15 minutes and get monitored. And everywhere that administers COVID vaccines, that has to have a protocol to have the medications and the plans in case somebody has a severe allergic reaction. So that is one. You're not going to get an allergic reaction if you never have the vaccine. You are more likely to have that serious allergic reaction than not, but the risk is very, very low, and you're able to put something in place in the unlikely event that somebody does have an allergic reaction. The second legitimate safety signal that was determined was in J&J, and folks may remember this. It was back in 2021. There was a very specific type of blood clot that comes with low platelets. It's not just a regular blood clot like a DVT. It's the fancy word is thrombosis with thrombocytopenia. But this ended up being detected in about 4 in every 1 million vaccine doses. Again, really, really rare. Little more than getting struck by lightning, but not nothing. And in that context, given that there is, that we didn't see this safety signal related to the mRNA vaccines, meaning the Pfizer or the Moderna, we now generally recommend the mRNA vaccines over J&J. We picked this up more in 2021, again, not something that's been sustained, but that's where you have this is why we do these monitoring, and then you make adjustments. I think the third one that got the most attention was myocarditis. Again, that's inflammation of the heart muscle. Usually people recover from this. It's not the same as a heart attack. It's not the same as creating long-term problems, but nevertheless, it is certainly concerning, and it can be dangerous. So we saw myocarditis, an inflammation of heart muscle, specifically among young males, so kind of in teenagers. This one was in about 10 of every 100,000 vaccine doses. So when you start to get into numbers like that, still extremely rare, right? 10 in every 100,000 is extremely rare, but it's, as opposed to the top two, which are 4 in a million, 5 in a million, that's very, very low. This is starting to get more into the range where there probably is some association, and so you want to really be careful about that. They were seeing it more often after the second shot. This is where anything that gets, you're looking in all of your safety studies, you're doing follow-up of anything that's reported into VAERS. They were able to show that it was much less likely and much less severe than the myocarditis from getting the virus itself, even in this age group. So this is part of, you make the decision. Should we continue? Does something need to be adjusted? And so what happened is there were many extra dosing and safety studies, especially with this focus. Power studies, it's called, to look for different outcomes. Myocarditis is a very rare outcome, but they wanted to make sure that we weren't seeing this as a recurrent issue. And it's part of what delayed the rollout of vaccine for younger children. You might remember it took a while to get the vaccine rolled out for younger kids because they really wanted to make sure that the dosing was good, that we weren't seeing safety signal changes, et cetera. And so this is where, this again is now when there's a safety signal that gets detected in any of the surveillance systems, it becomes part of the packaging, it becomes part of the monitoring. Sometimes you'll make recommendations around one type of vaccine over the other, but I want to reassure you that this is something that again. Legitimate safety signal, but very rare, still recommended, not a reason not to get the vaccine, but we use that safety signal to look at dosing, for the booster, for example, and for the vaccine for the youngest kids. There have been other safety signals that have been investigated, but not sustained. There have been safety signals looking at risks of things like heart attack and a number of other things, especially in older adults early on, that have not been sustained. And so right now, just to give you a sense of this, there's one safety signal that's being looked at. One of the, not VAERS, but one of the other systems said, we've got one place here that's flagging. Could we be seeing an increased stroke risk for people over 65 who received the Pfizer bivalent vaccine, right? That's the fall 2022 vaccine. Of course, lots of extra safety monitoring happening around the new bivalent vaccines. We've not seen anything concerning. Anytime you see any kind of safety signal, this is when you go and say, is this a real thing? And so the CDC and the FDA have looked at large databases with a focus on this question. They looked at everybody on Medicare. Remember, Medicare covers anybody over 65 in this country, meaning that is an excellent data source to look at if you want to understand risks for people over 65. So about 5 million people on Medicare have gotten those Pfizer bivalent doses, and they found no increased risk of stroke in that group. They looked at the VA, again, serves millions of veterans, lots and lots of people who have gotten the bivalent booster, looked specifically risk of stroke after that, no increased risk. Researchers have looked at this same question in other countries. Israel, which has really exclusively used Pfizer, did not see any increased risk with the bivalent vaccine for people over 65. Other European countries, no increased risk. So the safety signal is still being investigated, but based on this additional data, it's looking very, very unlikely that this is a risk. And certainly, again, huge concern for people over 65 who haven't had their bivalent vaccine, given that they're the most likely to end up in the hospital and to die. We are also still learning about the longer-term impact of COVID infection, but another reason I'm really careful to stay up to date with my vaccines, and I encourage everybody to, is I don't want, I want to help people avoid infection as much as possible. We're still learning about long COVID. But there's 3 recent studies, showing that after COVID infection, you have excess all-cause mortality related to cardiovascular complications, meaning more likely to have problems, heart and lungs, potentially for a year in both Italy and Spain. Same thing in Singapore. That was just excess mortality overall. There was a recent study in The Lancet that people infected with SARS had 3 times the risk of dying over the following year compared to those who have remained uninfected. And for those over 60, that increased mortality risk seemed to persist for a year after infection. So all of this is about really, as we learn more about COVID, more about long COVID, we want to avoid infection where we can. If people do get infected, especially those who are older, it's part of the reason I really advocate taking Paxlovid. You don't want this virus to kind of run amok in your body as much as possible. I don't want people having some longer term risk of cardiovascular complications, especially if they're older. And we are seeing that after COVID infection, but not after COVID vaccination. And so finally, vaccines have saved more than 20 million lives estimated in the first year across the globe. I can't tell you how grateful I was when we finally had a safe and effective vaccine here in Chicago, but even around the world. This is a recent a study looking at the global impact of the first year of COVID-19 with mathematical modeling, and you see that basically the black lines at the bottom, that's our excess mortality. COVID remains third cause of death. But if you look, that red line shows you basically what the model fit would have looked like without vaccines. And then the blue are deaths, therefore, that have been averted by people getting vaccinated directly. And then the green is deaths averted by vaccines indirectly. So not that people died not deaths that were averted because of COVID, but we think that probably some of this increase, for example, in cardiovascular, heart issues are probably related to people, getting COVID infected. And so getting vaccinated, preventing COVID infection or serious COVID infection probably helps with averting indirect deaths as well. So just in the U.S. in that year, they estimated that COVID vaccines prevented 18.5 million additional hospitalizations and 3.2 million additional deaths. Can you imagine where we'd be sitting right now without the vaccine? It really worries me. So just to sum up, that was a lot, but it's what we've gotten questions on. If you think you're up to date, but you haven't been vaccinated since Labor Day, it's time. Previously vaccinated Chicagoans aged 6 months and up are eligible for the bivalent booster. It gives you the best protection against Omicron. You can continue to get your updated COVID booster and your flu shot at home, even though it's January. Yes, we still have flu shots available. Yes, you should still get one. Yes, we still have updated boosters. Yes, you should still get one. We'll bring it to anybody in Chicago, no cost. Up to 10 people can be vaccinated. And as long as somebody is getting a COVID vaccine, we can do flu shots for everybody. So So give us a call or visit us at chicago.gov/at-home. You can get your free at-home COVID test if you haven't, covidtest.gov. You just put in your info. It's from the federal government. Review and place your order. We talk a lot about how to get free COVID tests, but make sure you always have COVID tests at home so you can use them if somebody has symptoms, you're traveling, you're exposed, etc. If you test positive for COVID, nothing has changed here. Days 1 through 5, you must stay home and isolate. If you're at high risk for severe illness, talk to your doctor about treatment. Day 6 or later, if you're feeling better, you can go out, but you need to wear a mask for days 6 through 10. And then finally, we're emphasizing really Vax and Paxlovid. If you're at high risk, vaccines are your best protection against COVID, but if you test positive, treatments are available. Paxlovid is an oral antiviral therapy for the treatment of mild to moderate COVID-19 in those at higher risk. And people age 12 and up who are at high risk of developing severe illness are eligible. Ask a healthcare provider. There's more information at chi.gov/therapeutics, including a link to the test to treat pharmacies. I also wanted to highlight that we newly here in Chicago, with some CDC funding, are running a rapid response evaluation and treatment program specifically for long-term care residents or nursing home residents. So if you or your loved one lives in a nursing home within the city of Chicago and recently tested positive for COVID, you can reach out to our local Treat COVID-19 program at 708-600-4233, or you can email at that address, and we can work with your nursing home, with your long-term care facility. We can come on site. We can do a telehealth consultation. We can courier the medications, whether it's Paxlovid, for example, to you. If Paxlovid isn't an option, we can come and do on-site IV administration of remdesivir. And we work to administer vaccines and do other things. All of this is at no cost to the facility, no cost to the residents. We're working with Simpar as the on-the-ground providers. And we just know that these folks living in nursing homes continue to be just at the highest risk. So it's important if you test positive, especially in this setting, that you are getting treatment as soon as possible. And so that's our new program to help with that. And then finally, we continue to operate Saturday walk-in vaccine clinics. So this Saturday, 9 to 2, we'll be at Olive Harvey College. Yes, we have the new COVID-19 bivalent booster. Yes, we have flu vaccines for everybody age 6 months and up. You can make an appointment, but you can also walk in. The combo you do not want is flu and COVID together. So get both vaccines. And as always, if you need a vaccine or have questions, come to chi.gov/COVIDVax or give us a call 7 days a week at 312-746-4835. All right, and with that, we're going to end the presentation and I will turn to your questions. I know there was a lot in there, but I wanted to, especially when we're talking about side effects, I want to have the background here. Okay. All right. So a number of comments about vaccine safety here. So Brittany Lynn from Facebook says, this chart doesn't include dysautonomia or POTS, which seem increasingly to be a common adverse event. So for those who don't know, dysautonomia, POTS, it's a postural issue. So I was showing there the most common adverse events. So there again, the reason I talked in some great detail through what we do with the safety signal and what's different is that it's not whether we're seeing POTS in young women, especially, is who we tend to see it in. It's whether that is being linked to vaccine or not. At this point, there has not been a safety signal that has been identified and borne out for that as an impact. So if you want to send a study along, I'm happy to take a look. We continue to explore, but that's why I went in detail over the safety signals that have been held up. Okay, Joyce and Larry Oliver from Facebook says, lots of young famous young people are dying from heart attacks. What about the less famous? This vaccine definitely needs to be investigated now. So again, there's been no link between heart attacks and this vaccine. for older people, for younger people, et cetera. And the vaccine is being investigated. It's being investigated through lots and lots and lots of different studies. And the reason I was talking about the famous people is that we have seen examples. VAERS, the Vaccine Adverse Event Reporting System, it's meant to be for people to report in and say, I had an adverse event. Doctors, by law, are required to report in if their patient has an adverse event after vaccination. But what we've been seeing, so maybe you misunderstood me, is there are people who are reporting into VAERS saying, this football player had an adverse event and I think it's tied to vaccination. That's not the football player reporting it. That's not the doctor reporting it. That's people reporting on their behalf. And has not been a link at all, that there is no suggestion that is a link there, but we've seen people, I was making the reason I was using the example of famous people is we've seen people sort of perhaps not understanding what VAERS is meant to be used for and reporting on things that they read in the news. All of those get counted in VAERS. It's a messy system on purpose because the idea is to look for signals and copy it. But it's why VAERS is not the only thing you look at, and it's not a link. Harmony Canfield from Facebook says, I'm in my 40s. I had COVID in April 2020. I've had to take 2 medicines for my heart that I never needed until I had COVID. So Harmony, I think COVID, especially in April of 2020, long before a vaccine was available, that really was the time that we were seeing the most severe outcomes, the most, of some of these longer term problems. We know that people are more likely to have had long COVID before. I obviously don't know your exact situation. Your doctor is best to sort of make the assessment of, given the heart medications or the heart problems that you've had, were those related to COVID infection or not? But that's, some of the reason I showed that data is to make the point that people have been more likely to have heart problems after COVID infection. Not after COVID vaccination, but after COVID infection. So if your heart issues have been related to COVID infection, I'm glad you're on medications to help treat them. And thank you for your comment. DS Shin on Facebook says, what are you expecting will happen here if XBB.1.5 surges like it is in the East Coast? So I do think that we will see an increase in XBB 1.5. It's the most contagious yet. And generally, when we see a subvariant outcompete, by definition, it means we will see more cases. And so I expect that we'll see probably some increase in cases here. The good news is it doesn't look like it's resulting in more hospitalizations, aside from just when you have more cases, more people can get hospitalized. But it's not looking like it's overwhelming healthcare systems. Thankfully, the vaccines, we're seeing some immune evasion, but the vaccines remain effective. The treatments, especially sort of Paxlovid, Remdesivir, remain good and effective. So that's all very good news. We have lost, I mentioned this a couple weeks ago, we've lost now some of the earlier antibodies that we used to use to build up immunity, like in people who have had transplants and the vaccine doesn't work as well. The monoclonal antibodies that were made previously do not seem to be effective, for example, against this XBB.1.5. So that's of some concern. But for the great majority, the most important things, the actual treatments, if people get infected, that seems to be fine. So I'm expecting some increase in cases, but I am not at this point expecting a huge surge like we saw last year that overwhelmed our hospitals, that caused major problems. I'm feeling pretty good about where we are right now. Even if we move to a high COVID level with this, we would issue a mask advisory and wait for that surge to kind of get through. When I would really worry is if we have a new variant of concern identified, one with a real new name, a new letter of the Greek alphabet. We have not seen that, despite the fact that some people are calling this the Kraken subvariant. That's not a scientifically named. That's not a scientific name for it. So, we'll see. My guess is next week, XBB.1.5 will be quite a bit higher than it was last week and the week after that. And we'll see some more cases here in Chicago. All right, Kristen Korkowski from Facebook. Is there a strong mask recommendation in Chicago yet? So we have not issued a mask advisory, if that's your question. We would issue an indoor mask advisory if and when we hit a high COVID-19 level. Thankfully, we are still at a medium COVID-19 level. Nobody is happier than me that we are sitting here in January still at a medium COVID-19 level. I've been traveling a little bit, and I've noticed, we are a little better here at putting the mask on when we're on the L, when we're in crowded situations. I think we're good for the most part about staying home when we're sick, putting that mask on if we've got a cough. Making sure that we have access to vaccines, making sure we have access to treatment. So, for all of you who cracked your window during your holiday gathering or tested ahead of getting together with older people, et cetera, I want to say thank you. And I'm very happy that we're still at a medium COVID level. So I, of course, we're at the same place that we were last week. I always say you don't have to wait for a formal mask advisory to put the mask on. I put it on generally when I'm indoors, certainly if I'm around people at higher risk, certainly if I'm on public transportation, et cetera. But no, the indoor mask advisory, the formal advisory, comes if and when we hit a high COVID level. And might that happen as XBB.1.5 gets here? Yes, it might. But that's different than hitting the levels where we're really overwhelming health systems. Okay. Ali Martel on Facebook says, I would prefer to see a statewide mask requirement again. If that won't happen, can Illinois at least require that all healthcare locations require everyone to wear masks? If you're medically vulnerable, which is a ton of people, we should not have to be sitting in a waiting room full of people who are unmasked. The CDC gives guidance, but shouldn't we be using common sense as well as looking at local conditions? So, Ali, really good comment there. So, what a lot of folks don't know is there's the COVID community levels that we always are referencing for the general public, high, medium, low, we're at medium. But there is a separate set of data that are used for healthcare facilities in particular. And when we're at higher risk in healthcare facilities, which we are at now, yes, masks should be worn, and that is included in statewide guidance. I very much agree with you that healthcare settings are both where people come. You can't avoid going to the doctor if you're immunocompromised or have medical conditions. You need to go into that space to get care. And we know it's a space that people come in with symptoms, even with COVID. And just where there is illness, where there's the potential for transmission. Yes, I agree very strongly, certainly here in Chicago, but even across Illinois, when we are at that increased risk for the healthcare facilities, and those facilities do know how to follow those, do get that information, masks should be in place at this time. Okay, so Renee Harkey on Facebook. Is Novavax available as a booster? Not at this time. Novavax, the last vaccine at this point to the party, original doses available, but not a separate booster dose. Good question. Rico MJ Hampton on Facebook. Can you get the COVID vaccine and the flu vaccine at the same time? Yes, you can. In fact, I gave the mayor her COVID vaccine her COVID booster in one arm and her flu vaccine in the other arm. I encourage that for people, especially if you're not somebody who gets a really sore arm or has fever or, has this robust immune response if you get a vaccine. If you're somebody who's had a really robust immune response in the past, whether to a flu vaccine or to a COVID vaccine, maybe you're somebody who might not want to get both at the same time, but that's for just comfort. That's not for safety. It is safe to get them at the same time. I recommend you do need to get them in 2 separate injections. It can't all be in one syringe together. I recommend doing one in each arm so that you have your own little study on yourself. If you have a sore arm, which one was the more likely to give you the sore arm. But yeah, I encourage people to get both at the same time. That's what, in my clinic, that's what I encourage my patients to do. If you prefer to space them, you can, but you should get both. And I do think we're going to be on a path, most likely, COVID's not going anywhere. My expectation, we'll see for sure, is that probably every year, in the same way we make a new flu vaccine every fall based on the strains of flu that are circulating, my assumption is we'll probably be making an updated COVID booster every fall too. And so I do think it'll be something where, down the line, you'll probably be getting both of those together. Maybe even, eventually in a single shot. But right now the storage requirements are different. Some require, a certain ultra cold storage. Like, they're not quite in a place yet where you can just put them in one shot together, but in terms of getting them at the same time, you can, and I would recommend you do. Alexandria Deanne from Facebook. Is there a concern about measles here, given the Ohio outbreak? So I talked to the commissioner where their measles outbreak is. Measles emerges where vaccine rates fall or in settings where measles vaccination has not been given. I worked on a measles outbreak actually here a few years ago in suburban Cook County. And in that case, measles got into a daycare and almost every child under the age of 1 got the measles because we can only start vaccinating at about age 1, typically, for measles. So where you'll usually see the spread of measles is where you have a population that isn't vaccinated. That vaccine, thankfully, you just get your vaccines when you're young, typically one around age 1 and second one around age 4. We give it as part of the MMR vaccine here. So you get your measles, mumps, and rubella all together. If you've had that vaccine, even if there's measles circulating, the chance of you getting measles is very, very low. We do have a very high measles vaccination rate in Chicago, above the national average. So I don't worry at a population level about measles, but I always worry if there are subgroups of people who have not had their vaccine. That is generally where we will see it spread. So not hugely concerned, but certainly continuing to monitor. Every time we have even a single case of measles, the health department does a lot of work to identify everybody that person's been in contact with. If there are people who are unvaccinated, or for example, women who are pregnant, we will give some antibodies to help protect the baby because you can have birth defects and other issues. And it's a lot of work every time there's even a single case because we want to work to make sure that case doesn't spread further. Okay. We are just about at time. We started about 2 minutes late, or a few minutes late. So maybe I'll just run through a couple of these. Riley Scully on Facebook says, why are the vaccinated getting so sick? So I don't know if you mean getting sick from COVID or getting sick related to some of the other things that we were talking about. But what I will tell you is that at this point, it is very, very clear, and if you go to our dashboard and go to vaccine effectiveness, you can see the Chicago data on this, that people are much more likely to get sick and to get hospitalized and to die if they are unvaccinated. So COVID is serious. Like, there are people, even who are up to date with their vaccines, who can get a breakthrough case and get pretty sick. We are definitely still seeing it. Like, I can't tell you how much more, people always say COVID's just like the flu. I wish COVID were like the flu. COVID has killed 10 times the number of people. Like, it's so much more serious when people get infected. The vaccine is your best bet. I always say, especially if there's people who are older and they're up to date with their vaccines, like, thank God they're up to date with their vaccines. Because if they're if they get a breakthrough case and they're that sick without it, then, very high chance they would have been even sicker or even died with it. But that's the other reason why I really want to emphasize that even if you're vaccinated, if you're at high risk for severe illness, which I consider to be anybody over 50, anybody over 65, people with underlying, asthma, cardiovascular disease, diabetes, if you are at high risk for severe illness, whether or not you are vaccinated, if you get COVID, I recommend taking one of those medications, like Paxlovid, for example, because it doesn't stop you from getting infected, but it cuts the ability of the virus to copy in your body, get into your lungs, get into sort of your circulatory system, make you really sick. And so, Riley, to your answer, if there are people who have never had COVID or up to date with their vaccine, if you get COVID, don't just assume it's going to be nothing. If you're at high risk, please take the medication. It also, it definitely cuts down on those more severe illnesses. At the very beginning, we didn't have vaccine or treatments. Now we have both, and we want to use both of them, especially for people who are at higher risk. Good question. All right. All right, and I think we'll end with Christina Ewing Christofferson from Facebook says, why is this propaganda campaign still going on? So Christina, the reason that I spent about half an hour today going over some of that data about vaccine safety, how and why I know the vaccine to be safe and effective, why I take it and recommend that everybody in Chicago absolutely stay up to date with their vaccines, is because we are still getting a lot of questions about it. And so I don't consider it propaganda personally to answer people's questions. I was doing this Facebook Live 7 days a week at the beginning of COVID, and then we've sort of dropped down, but we've stuck to doing it once a week because Chicagoans still have questions about COVID and about COVID vaccines. And I am really committed to transparency and to being as open as I can be with you as we continue to learn about COVID. It's not going anywhere. It's why I've pulled in, the opportunity pretty much every other week. I try to bring on some guests. We talk about things besides COVID, because the health department does a whole lot more than just COVID. But I will continue to do this for as long as we continue to get questions. And boy, do we continue to get questions. So that's my goal. My only goal is to help keep Chicagoans from getting sick, to help keep Chicagoans from dying, to increase trust, I would hope, in the health department. I don't make any money. No, I see a question. I don't make any money when people get a vaccine. I wish I did. Not really. I don't wish I did, because I am motivated in promoting vaccines because they save lives, including here in Chicago. More than 8,000 Chicagoans have died from COVID-19. The vaccine has made the biggest difference in that, and it just makes me sad when people are reading other information and still not believing that the best choice for them or their family is to get that protection against COVID-19 infection. So I plan to continue to do this, and you certainly don't need to watch if you feel like you've had all of your questions answered. But I'm glad you are watching because it suggests to me that you are interested. And I like people who are interested in public health and who want to make sure they have the most up-to-date information to make decisions about protecting themselves and their families. I also always encourage anyone with any questions about their own health or their own vaccine decisions, please talk to your healthcare provider. That's the person who knows your health history best, that can make the best advice, that can answer your specific questions. Because I can't answer all of Chicago's questions, even when we do this once a week. So with that, thank you. We will be back next Tuesday, January 24th. We may possibly have the Illinois Department of Public Health Director, Samir Vora. He's down in Springfield, so we're trying to figure out if we can kind of do it remotely or what that might look like. But certainly I get a lot of questions, even today I got some about what's happening at the state level. And, we talk a lot, we have a good relationship. And so we are working on figuring out either a time he's in Chicago or perhaps even doing it virtually next week. So, all right, we are at time. If we didn't get to your question, we will work to take it next week or go to our website where we continue to update it with questions that you all put in. Thanks for your attention. Thanks for your questions. And we'll be back next week. Bye-bye.